All right, YouTube is up. Good morning, PT on Ice Daily Show. My name is Dr. Ellison Melrose. I am lead faculty with the Drug Handling Division of ICE. I am here to piggyback off of the Fitness Athlete Fridays for the past 2 weeks. 2 weeks ago, we had Alan going over the evaluation process for determining if training is subscapularis muscle. And then last week, Zach Long went over some treatment techniques, and he hinted at one of the most efficient ways to treat the subscapularis muscle, which is dry needling. So what I wanted to do today was to go over a demonstration of how to needle the subscap muscle safely and efficiently. So in order to be able to needle this muscle, our patient needs to be able to get at least 90 degrees of shoulder abduction with some moderate external rotation as well. So patient positioning, they're going to be laying with their arm up in this abducted and externally rotated position. My patient here has some decent mobility, so she doesn't have any issues getting into that position. But for someone that maybe struggled with maintaining that position for the duration of treatment, we can bring their shoulder down slightly, and you can also prop their wrist up so they're not in so much external rotation as well. But again, this patient doesn't have issues getting into that range of motion. The reason we need to have this position is because we need this scapula to be protracted out from underneath the thorax for this to be a safe and effective dry needling technique. So we need to be able to palpate the lateral border of the scapula and appreciate the difference between the lateral border and of the scapula and where the lateral border of the thorax is. In this position as well, we can think about the rib cage. It's not perpendicular with the table in this position. It's kind of diving around. It's oval shaped, right? So it's diving around and posterior and a little bit medial there. So if we get that scapula out from underneath that rib cage, we have some good real estate to needle this muscle. This is a direct technique, so when we go over different types of techniques, we have a threading technique and a direct technique. Typically, when we talk about direct techniques, they are direct to a bony contact. So in order to ensure that we're at the depth of the subscapularis muscle, we need to have a bony contact with our needle in that subscap fossa there. So again, patient positioning here. Some other considerations in this area. We have the lung field, appreciating where that rib cage is and how it's diving away and where our scapula is in relationship to that. But we also have some other sensitive structures in the axilla. So we have our brachial plexus that actually runs just anterior to the subscap muscle and exits down the medial humerus here. So we want to orient ourselves to where the brachial pulse is, as to avoid needling in that region, right? So the best window for subscapularis is going to be just distal to that brachial pulse, but still fairly proximal in the axilla. If we go too distal, we're likely going to miss that bony contact that we need for ensuring that we're in the subscapularis muscle. Some other considerations here is we have a really strong and powerful motor nerve, the thoracodorsal nerve, that runs along that lateral border of the rib cage, which innervates the lat. So if we were to interact with that, we would likely get some fairly strong lat muscle activation. So typically it kind of looks like that sprinkler dance move that we all know too well from middle school dance. But so those are our main considerations. So lung field and some other sensitive structures, the brachial plexus and brachial artery and vein in that axilla. So again, first we want to bring our patient into this abducted, externally rotated position. If you feel like you can't appreciate or you don't have a good real estate of that scapula. You can assist by protracting, like grabbing the medial border of the scapula and pulling it laterally. So again, we should be able to appreciate lateral border of the thorax is there, lateral border of there. So we have a good 2 inches room to play with. A lot of these athletes that have they're sort of thinking the athletic population would be one where we want to treat this. CrossFitters, for example, they also have fairly hypertrophied lats. So that's another thing that we have to appreciate is we're going to have to be sinking in to get, again, that bony contact on the scapula. Another common patient population that you may be needling this muscle in is going to be the thawing stages of frozen shoulder, right? So this person was able to they're now in that pain-free, able to access at least 90 degrees of shoulder abduction or post-op rotator cuff where they're really struggling with some of that end range shoulder abduction, external rotation and shoulder flexion even. Subscap is going to be a good muscle target for those patients as well. So before we do anything, we want to prep the tissue. So we're going to clean the skin. I prefer to do most of my needling techniques in standing, especially for this muscle, as sometimes our fingers are not going to, like just our finger pressure is not going to be enough pressure to sink into, approximate that subscap fossa that we want to. We're going to be needing a longer needle than we think. So for Sam, I have a 75 millimeter needle. Some folks, you may even need longer, and that's just based on excess muscular tissue, the lat, the pec muscle that we're kind of orienting ourselves around, the skin recoil. So as we compress that tissue, once you release, that skin recoil is going to potentially move that needle if we don't have a long enough needle, and it will choke up on the handle there and it'll pull it off of that bony contact that we've spent so much time fighting. So we want to make sure that we have a long enough needle to maintain that bony depth. Another thing to consider is when we are with ice, we are dry needling with E-stim, right? So we're not doing a ton of heavy pistoning. Again, there's a lot of sensitive structures in this area, so it's usually not very comfortable to piston a lot. So we're going to be wanting to layer in the strategy with E-stim. When thinking about E-stim, you always want to be thinking in pairs. So how can we pair this muscle with another muscle that may be doing something, a similar movement pattern that may be also restricted, or something that's going to reach that motor threshold at the time. So we want to be thinking about muscle spindle density in our muscle tissue of what's going to reach that motor response around the same time. Typically, I like to pair subscapularis with the clavicular fibers of pec major. So we have another technique for pec major clavicular fibers. Of course. Why was I logged out? Okay, well, I was logged out on Instagram, so we're just going to continue on YouTube here. So we want to maintain we want to be able to pair this muscle with another a muscle that has a similar muscle density. So, and it's also going to be limiting some of that external rotation in this position as well. So I like to pair those muscles. For today, we're just going to go the dry needling demonstration of subscapularis. So again, we want to orient our patient into abduction, external rotation. We want to maintain appreciation of that lateral border of the thorax. And then we're going to compress the tissue down, down towards the subscap fossa. Usually your palpation here is going to be the most assertive part of the technique. And you might get what we call the Gunna sign, where some people don't tolerate that very well. To orient ourselves to that brachial artery, we can find the pulse. So typically I would come around to the other side, palpate the pulse here. Pulse is under my index finger. So I've oriented myself to where that neurovascular bundle is, and I'm going to be treating just distal to that. So right in here, all right? So we have an appreciation of that anterior surface of the scapula. Again, using a 75mm needle. So I'm doing firm palpation. My medial aspect of my hand, so my pinky and ring finger, are appreciating that lateral border of the thorax. My needle angle is going to be perpendicular to the scapula here. So really it's fairly directly anterior to posterior, almost paralleling the rib cage, anterior to posterior. So we're very close to that rib cage, but we're paralleling it, so we're not going to be interacting with intercostal space or lung field here. So again, appreciating lateral border, knowing where that neurovascular structure is, that main safety, lateral border of our scapula, firm compression down. I feel that muscle. You can always do a little internal rotation, good, and relax, to feel that muscle activation under your fingertips, compressing, giving yourself a little treatment window directly anterior, posterior. You're on bone right there. So if you look at this, you're like, dang, she's got a lot of needle left over, but let's allow for that tissue recoil. So as we let for that tissue recoil, we have about a centimeter left. So a 60mm needle would not have been long enough to appreciate that depth of the subscap. As we allow for that tissue recoil, you may start to see like the needle changing directions a little bit, and it may look a little bit suspect. But knowing that we're on that bony contact, that needle tip is not going to be going anywhere once we've reached that depth of the scapula. So we can allow for that tissue recoil and set up our next needle and then set up the stem and feel fairly confident that that needle is not going to go anywhere. Main concern with safety here is if this person were to move their arm, right? That would be something to be a concern. Or if we're interacting with that thoracodorsal nerve and we get a very big motor response into that sprinkler dance move. So when we are bringing the stem up and looking for that motor response, typically I would suggest maintaining that appreciation of where that lateral border is and kind of bringing that needle back into its original orientation. Once you feel confident that we're not getting any sort of interaction with the thoracodorsal nerve or anything that's a less of a motor response than what we want or more of a motor response than what we want, we feel fairly confident that leaving that needle at that bony contact is a safe needling technique. We are rarely, or really ever, we shouldn't be leaving our patients stimming with needles in them by themselves. I feel like that is a best practice to be in the area with our patient. And so if this needle were to move slightly or anything like that, you can always maintain contact or redirect as needed. So there we have the dry needling demonstration for subscapularis muscle. Again, my name is Dr. Ellison Melrose. I am lead faculty with the dry needling division. Some of our upcoming upper quarter courses where you can catch this technique and a bunch of other techniques. We have a 3-day course in Longmont, January 26th through 28th. Paul will be out in Wisconsin, February 3rd through the 4th. I will be down in Greenville, South Carolina, February 17th, 18th. Paul will be out in Bozeman, March 2nd through the 3rd. And then I'll be out in Maryland. It's Sparks, Maryland, 24th through the 22nd through the 24th. So there we have our upcoming courses, and this hopefully was a good review or a new dry needling technique that you guys can use in the clinic. Awesome. I'll turn this off real quick. And then